So let's take up the actual, definition of recurrent pregnancy losses. So diagnosis of RPL is actually more than 2 failed clinical pregnancies. 2 failed clinical pregnancies, and clinical pregnancies I'm talking in terms of maybe, biochemical pregnancies, ultrasound confirmed pregnancies, but has to be clinical pregnancies. Not that patient has just not, had period, it is overdue. She's thinking that she's having a pregnancy, and now then she gets, whether, it was actually a pregnancy or not. That happens at many times. Patient is not pregnant, period gets overdue for 2 days, 3 days. That is not actually clinical pregnancy. So this is very important thing. There are many patients, especially in Indian scenario. See, when you take a history from any patient, she comes to you and she says that, I had 2 pregnancy losses before. So very important is for you to elicit this thing. This thing is going to be asked in your questions, in your Viva. That how do you know that she was pregnant? So if you ask her, how did you know did you do a pregnancy test at home? Did you had that kid? Whether you visited any healthcare center? And whether you got any ultrasound done or so. So in that case, if she gets a thing positive, then we get to know that maybe she had a pregnancy and then that got aborted, and then we take it seriously. So diagnosis of RPL is more than or equal to 2 failed clinical pregnancies. Clinical pregnancies, I'm insisting. We choose to define RPL as 2 failed clinical pregnancies less than 14 weeks as the most inclusive and currently accepted definition. But this is, this is our consensus. I'll just be briefing you about the various, committees by various societies and their definitions. Now, over here, have a look at this. It includes biochemical pregnancies. That means maybe there was no gestational sac, but there was UPT positive. That means there was some pregnancy, which we called chemical pregnancy. It stayed on for a while and then it got aborted. So you don't have ultrasound confirmation, but you do have a UPT confirmation diagnosed, and of course, those diagnosed by ultrasound and histopathological findings. The definition also includes pregnancies of unknown location, but not confirmed ectopic. See, ectopic and molar pregnancies are not included as, pregnancy losses, because ectopic pregnancy, it's doomed to, to be lost. It's doomed to die. Molar pregnancy, same. It's not a viable pregnancy. It's not going to continue. So then what do I mean by the pregnancies of unknown location? What do I mean by that? Can anybody tell me? It includes pregnancy of unknown location, but not confirmed ectopic. What is the difference? Come on, guys. This is a little intriguing thing. I want to know whether you understand that or not. You can write in the chats. Come on. Let me know whether you understand or not. So I haven't got anything in the chats as of now. Guys, I hope you know this, right? That there is a way to go. You can just write on my Telegram channel. You've joined through that channel. You can just, write down the comment, leave a comment when I'm asking you a question. And it'll be a more interactive session. You can also unmute and speak. I have no problems. But just remember to mute it back. All right. Okay, fine. So I understood that maybe you were not very clear. Now I'll tell you, pregnancies of unknown location and viable pregnancy. There are certain ectopic pregnancies which are viable. Cornwall pregnancies, pregnancies in the non-dominant or dominant horn of the uterus. Okay, there are 2 horns. Biconvate horn is confirmed ectopic, but maybe viable. One answer I'm getting. Let's see. Ectopic pregnancies confirmed ectopic. Maybe viable. Yes, definitely. See, ectopic, I'm talking in terms of, ectopic confirmed, but I'm talking in terms of, pregnancy of unknown location, abdominal pregnancies, they are, viable pregnancies. Sometimes even ovarian pregnancies are viable pregnancies. And then, of course, pregnancies in the horn of the uterus, the non-dominant or dominant, the other horn of the uterus. So anyways, let's not get too much into that because that's a rare to rare entity. Let's focus on the important things. So what RCOG says, it includes 3. That means just imagine patient has already lost 2 pregnancies, 2 known pregnancies, clinical pregnancies, and still you are sitting over it because you were waiting for the 3rd to happen, and then you will start, calling it recurrent pregnancy loss. And that would has to be, consecutive losses. And it's not required to be an intrauterine. That means it's including ectopic as well in this. It's including, the confirmed ectopics also in this, biochemical pregnancies also in it, but it has to say be consecutive losses. But more liberal is ASRM and ESHRE. and I'm with them, because I don't think you'll wait for the third loss to happen. You will just cause the second loss that happens and you are alert. And be it consecutive or be it not consecutive, that is also there. All it has to be, it should be a clinical pregnancy, either confirmed by histology or ultrasonography according to ASRM. That has to be, you know, a viable pregnancy, a viable in the sense of pregnancy actually per se, intrauterine or, you know, whatever. So we should know that there was a pregnancy, there was a gestational sac at least, not just, you know, a pregnancy test positive. This is according to ASRM. H-rate includes UPT positive as well. So I am with H-rate because they say number of pregnancies, at least 2 or more, needn't be consecutive, and biochemical intrauterine pregnancy of even unknown location is included in this. So now we get on to the causes. Now, whenever these, your Viva is asked on recurrent pregnancy loss, very important thing is, you know, what are the causes of, this recurrent pregnancy loss, and how much weightage should we give to these causes? And this is what the, patient also wants to know, the examiner and the exam would want to know. Because anything which is very ambiguous with the patient's main cause of concern is, which also becomes a cause of concern for us when we are interviewing you for your, whether you understood the topic or not. So recurrent pregnancy loss, 3 to 5% is because of genetic causes, just 3 to 5%. We say it's a lot, but actually if you see, you know, the early losses, that means before 10 weeks, mostly are because of genetic causes, and I'll tell you what all they are. But in toto, you know, when we talk about mid-trimestral losses as well as recurrent pregnancy losses, that means all losses before 20 weeks of gestation actually. In them, we say anatomic it encompasses 10 to 20%. Now, remember that we've already had this, my case discussion includes cervical insufficiency separately and recurrent pregnancy loss separately. So when I'm talking about recurrent pregnancy loss, right now, I'm not talking about cervical insufficiency, right? So what over here, what you can see is actually taking in, encompassing before 20 weeks, the losses, right? Recurrent pregnancy losses before 20 weeks. So it is now saying that 10 to 20% could be because of anatomical factors. And amongst the anatomical factors, can you tell me which anatomical factors are important, which can cause recurrent pregnancy loss? Not difficulty in implantation, recurrent pregnancy loss. There are two categories. Okay, one of them will not let the implantation take place. For example, some mucus fibroid, some mucus polyp. Yes, very good, Sahili. I'm very, very happy with, you know, the promptness of this girl. Very good, Ume. Uterine septa happens to be a very important, reason of this, recurrent pregnancy losses. So what we see basically in hysteroscopy when you're doing especially for this patient with recurrent pregnancy loss, is actually a septa. And it has to be, you know, a big, thick septum, vascular septum. Only then you'll go ahead and cut it. I'll talk about it later. Otherwise, if it's a thin, flimsy, septa, you might as well leave it, because that's not the cause, even with recurrent pregnancy loss. But that's most probably not the cause. You can even go for a 3D ultrasound to find it out. But if you are a good hysteroscopic, laparoscopic surgeon, you can do both the things in the same go. So yes, very correct. Uterine septa happens to be a very important, and this diadelphys uterus diadelphys, very, very important. Not so much arcuate uterus. Yes, you're right, Ume. Uterine anomaly happens to be, and which uterine anomaly? Then the examiner is going to ask you which uterine anomaly. So uterus diadelphys is very important. Biconvate uterus is also important for recurrent pregnancy loss. Mostly actually preterm labor, but you can still say not arcuate uterus. Then we go on to the endocrinological causes, and endocrinological causes, very high levels of sugar. If a patient is already diabetic and she's got high HbA1c, uncontrolled sugars, that's a cause of recurrent pregnancy loss. Then, of course, thyroid disorders with anti-TPO antibodies, and I'll get to that as well, is a very important cause of recurrent pregnancy losses. Are you seeing, guys, that there is nothing called torch panel over here up till now that I've been discussing? You will not utter this word in the examination. Examiner might ask you, and more, tell me more. You are not leaving and going to that point of torch, right? Never utter this word torch, no matter all your tests they end, because this is what the examiner wants you to fumble at. They want you to utter this word, and then you'll get a big 0 in your exams, because torch might cause sporadic loss in one of the pregnancies, but it's not a cause for recurrent pregnancy loss. I'm saying that over here so that it gets embossed in your mind while understanding this topic. Now let's go to immunological causes. Come on, let me hear immunological causes from you people. How many do you know? Of course, I've written thrombophilic and immunological. So over here, what exactly do you include in immunological causes?